I'm very excited to be here today. Can people hear me all right? I have a quiet voice. Okay, so let's see where we're at. First of all, just the first time I was invited to speak here was 2 years ago, and the plan was that I was going to speak on emerging infectious diseases. And the 2 years ago, we canceled this conference because of an emerging infectious disease and moved kind of straight into, COVID pandemonium at that time. So my plan at that time was to speak mostly on acute flaccid myelitis, which is the polio-type paralysis that's happening with enterovirus D68. That was my plan, and it was a little bit edgy, I thought, because I thought this is a disease that's only been around for 5 years, and to give a whole talk on a 5-year-old disease is really edgy, and I've gone over that as I've given endless talks on COVID when, just as we're learning the data, I'm giving the talks on it. So, all right, so talking about post-COVID in general, first, the objectives of today, we're going to be able to define the condition of long or post-acute COVID, review the presentation of it and the pathology of it. It's one of these things, kind of like we talked about in the last lecture. If it's a fibromyalgia type thing, well, what is it? How do we define it? How do we know what it's presenting like and that it's real and to give that information to patients? And then what is the evaluation of it and what is the management of it? Okay, what are the names of it? Let's get a name first. And you guys, there's not a name. These are the names we've got so far. Long COVID, post-acute COVID-19, long-term effects of COVID. So when you search literature, you're searching for all of these things because we're still defining it. The one that is taking just the last 6 months is really kind of digging in, is the post-acute sequelae of COVID-19, which is PASC. So that's what you're seeing most often recently. But the thing to know while we're defining it is that it's a debilitating condition and it's affecting a large proportion of the people who've had COVID disease. About 30% is where we're at as far as what percentage of the people who have COVID disease are getting these long-term effects. All right, so the definitions, this is again per CDC and WHO, defining it. So acute COVID-19 is the disease and all symptoms kind of in recovery period up to 4 weeks. So within that 4-week period, you're still in acute COVID and acute COVID recovery. Once we get into the broad range of symptoms that are happening after that, we're calling it the post-acute COVID. And these are the mental and the physical symptoms that are clustering. And they, per definition, it has to last more than 2 months after acute COVID. So 3 months total is the definition. So that's now, as we're trying to get a good data set of information, that's what we're looking for. Okay, what is affected in acute COVID-19? Let's do a refresher course so that we know what makes sense from the pathology of acute COVID-19 going into long-term effects of COVID-19. Most of the data sets coming from acute COVID-19 comes from hospitalized cohorts, most of it. So it's not fully representative, but it does give us a very wide picture of the impact of COVID. So with acute COVID-19, refresher, everybody should have this one down by now. SARS-CoV-2 virus is binding the ACE2 receptor, and that causes several genes to be expressed. That causes inflammatory pathways to be, let's see, what's the word? Started. We start all of our inflammatory pathways, and then we get the widespread inflammatory responses, the thrombosis, and the microangiopathy through this process that causes pathology. All right, almost every organ system can be affected by COVID. So let's go through them. You're gonna have your systemic manifestations, fever, very common if you're hospitalized, less so not hospitalized. The myalgias are very common, and the fatigue is notable. So we know systemically. Then we definitely have the cough. That's a dry, way more than productive cough in the majority of patients. The dyspnea presents a quarter to half of the time, way more common once they're hospitalized. And then the URI symptoms were not as common with our first year of variants, and then it's becoming more common in the second year of variants. And then the triad of cough, fever, shortness of breath was very indicative of somebody who is going to need hospitalization. Going on to GI manifestations, so we're seeing nausea, vomiting, diarrhea in up to 34%. Definitely the US is way higher on GI manifestations than other countries. I don't know if we're looking for it more or if we have more unhealthy digestive systems to start with. This is becoming more common in the more recent variants and more common in children to see the GI manifestations. It can be the only symptoms around 10% of the time. The cardiac manifestations are notable of acute COVID. Arrhythmias are common. Cardiomyopathy is definitely being seen in all the early ICU reports, and then what's been seen the last year is not there nearly as much. We have cardiac injury with troponin leak, and we have lots of myocarditis being described. This is something that's interesting because the myocarditis is described in the acute setting of hospitalization. It's also described in people who recovered well without problems, and then the myocarditis presents in the second week. The ENT manifestations are mostly taste and smell associated, and they can occur before any other symptoms, and then rarely they present as the only manifestation at all of COVID. This totally happened with one of my coworkers who was eating her jalapeno chips, and there was no jalapeno to her jalapeno chip, and she panicked, and we tested her and she was positive. So it can happen that that's the only symptom you get at all. The ENT manifestations with acute COVID are mostly resolving around the 30-day period. Ocular manifestations are happening as well. Conjunctivitis is the most common one, but a foreign body sensation is well described. Hematologic manifestations is the hypercoagulability is severe cases. We've got thrombotic events, especially happening on our hospitalized patients with COVID, and nicely described. So we can have the DVT or PE happening in, nicely described hospital patients, also happening in outpatients. The renal manifestations are super interesting. So we're having acute kidney injury in the hospitalized cohorts, and then is this because fluid shifts? Is this because the virus is impacting the kidneys more because of the higher expression of ACE2 in the kidneys, or is this just inflammatory effect? So, all right, then the derm manifestations, the rash is seen 10 to 20% of the time, and it's anything. At this point, it's anything. Erythematous, urticarial, vesicular, it's anything. Neurologic manifestations are notable throughout the process. So we've got, the confusion, the tired, the headache happening acutely. And then we have, more complicated things that come up with severe COVID. So now we have a nice set of patients who have COVID encephalopathy, which is no CSF with COVID virus, but an encephalopathy picture regardless. Cognitive dysfunction can be seen in recovered patients, and we'll get into that a little bit later. So COVID-19 is now a very well-described cause of stroke. It's ischemic stroke. 2 to 4% of all patients will have it, and usually an older patient. And again, they've done some studies. Is this because they're acutely ill with a respiratory virus, and they've compared to influenza, and we're definitely more common in COVID patients than we are in influenza patients. Let's see. There are small case series that are showing that it's there in young patients without vascular risk factors as well. So it's not just that COVID is, predisposed to go to patients with, significant health issues in the first place. All right. I wanted to do a quick review on Guillain-Barré syndrome and COVID-19 when we're kind of going through the neurologic manifestations. So this is a small case series. So the link is coming from very small case series, and then I'll tell you more in the next slide. But we're presenting 5 to 16 days post-infection, so we're in a very tight time frame. And the cerebral spinal fluid is classic GBS, where white blood cells in the CSF are low or normal. And then we have the elevated protein count in the CSF. No CSF is positive for the virus. And then the EMG nerve conduction studies are consistent with the axonal variant of GBS. Let's see, the MRI did show some nerve root enhancement. So we've got it described. How common is it? So these are the much larger epidemiologic studies. So going kind of looking broadly, what are we seeing? Are we seeing epi increases with these bumps of COVID, all the different waves of COVID, looking at the GBS cases, and there's not a link when we look at big epidemiology. And is that because COVID's not doing it and all the other infectious triggers are down? So GBS actually goes down because in the last 2 years. So when we used to see our winter spike of GBS because all of our infectious triggers go up, we're not seeing that right now. In the last 2 years, we've got that data. And overall, GBS is just running low since COVID-19. Okay, so now I'm going to transition. Now that we kind of have a good idea of pathology of acute COVID and what we're seeing, let's go to the post-acute COVID symptoms. So, okay, good, we can see this. The good thing, so this is an overview slide where we can kind of say, okay, what are the main symptoms we're seeing and how debilitating is it for how long? So we're debilitating 10 to 80% of the time, depending on the symptom, and it's lasting several months. So that's kind of our baseline information. The average number is 30% of patients experiencing more than one persistent symptom greater than the 3 months. Most of this data comes from early cohorts with our earlier variants. And before we had significant vaccine protection in the community. So we're waiting on the next wave of data to see if we get impact from the variants changing, becoming slightly less severe, and the vaccine protection in the community. So the big thing to note, this is on the bottom of the slide, is the reduction in quality of life by greater than 50%. So believe your patients when they don't feel well and they say it started with COVID. The most common persistent symptoms, the reason people will show up in your office wondering how to get help: fatigue, dyspnea, chest pain, and cough. So, and fatigue, we've got up to 85% with that. The chest pain and chest tightness is the 12 to 44%, so that's a very common complaint. And the dyspnea, we'll get into some details on the dyspnea as well, because people feel really debilitated by the dyspnea. The less common symptoms, so the loss of smell, persisting for several months. I've had several patients presenting with the joint pain, the bone pain. They feel like it's deep in their bones, and they all want to be worked up for leukemia because they are sure that that has got to be what's going on with them. Headache, persisting, the dry eyes, dry mouth, persistent rhinitis, a very distorted taste. So patients during COVID and this post-COVID, the distorted taste is that kind of a constant metallic taste is the most common thing people will discuss. Dizziness can be persistent. That can be from orthostasis. It can be from a POTS-like picture, dysautonomia, or vertigo. Then we have the myalgias, insomnia, alopecia, sweating, diarrhea, are all nicely described. Okay, so let's look at some studies. So this is, again, a hospitalized cohort. So I'll try to make sure you know if I'm talking about a hospitalized cohort or outpatient cohort. But a hospitalized cohort looked at post-discharge. So about 70 days post-discharge, what are people reporting? And so we've got fatigue being obvious, breathlessness being an obvious one. This is an ICU patient in orange versus a ward patient in blue. So note that there's a discrepancy, of course, between ICU patients and their persistent symptoms and ward patients, but it's not incredibly different. And I did think this was notable to say that it's not a large difference for several of these items. Voice changes on this study. Initially, everybody thought voice change complaints were because of their intubation and their prolonged ventilation, but you guys can see that our ward patients are complaining of voice change as well. So let me think. I think we covered everything on this slide. Let's go to our next one. This study is fantastic. So our initial Wuhan, China cohort of patients, so all of those hospitalized patients, the thousands of patients who got hospitalized in the first place, they have now had a 1-year follow-up. So in this 1-year follow-up, we have 2,400 patients who did a full survey by phone after their hospitalization. So 1 year out, we have severe patients versus non-severe patients. That's WHO criteria. And we have 45% of patients reporting at least one symptom persistent at the 1 year. The most common symptom was fatigue. But then this was the first study that got sweating on the list. So persistent sweating is high up on the list for reported symptoms a year out. So if people come to your office and report that, validate what they're experiencing, because this is the study that got it on the charts. Older age and the more severe disease are linked to the persistence of more than 3 symptoms at the 1 year. So you'll definitely want to know how severe the disease was when you're evaluating. All right, this is a cohort that was just ICU patients. So if you have someone who's been to the ICU, this is a great study to be able to figure out what they have. This is 1 year out as well. The ICU patients had to, of course, survive the ICU experience with COVID and then have their follow-up at a year out. They are age 16 and older in this cohort. 74% have at least one physical symptom persisting at 1 year. 26% have the mental symptoms persisting at 1 year, and 16% have cognitive symptoms persisting at 1 year. They have lots of information on here, but I love that 10% exceed the PTSD impact score still at 1 year. So the process of ICU COVID hospitalization is a very large magnitude when we're looking at their emotional, mental well-being out a whole year. A year out, depression is still at 18% and anxiety is still at 18%. Okay, what happens in children? So most of the studies cut off at 16 for all of these adult cohorts. What's happening in age 6 to 16? We do have a cohort of this patient population, and long-term symptoms are less prevalent. None of the children in this cohort were hospitalized. The most common symptom was persistent tiredness, difficulty concentrating, and increased need for sleep. So that's what we're seeing in a younger cohort. There are, I think once they're over 16, I've got plenty of patients with long COVID symptoms who are the older teens and needing evaluation. So a switch must flip in that late teen period. What is the time for recovery? So people want to know, when will I ever feel better? So you're going to just give people some expectations that you're going to have a longer recovery course if required hospitalization baseline, if you're an older patient, if there were pre-existing conditions that have impacted the severity of COVID-19 or just pre-existed or impacted your overall health. Patients with medical complications during COVID, like a bacterial pneumonia, a venous thromboembolism, are all going to have a longer recovery course as well. And then the prolonged stays, hospital or ICU, are all longer. So that's your baseline. You're going to take a longer time. But data has now nicely described that less severe disease, they were never hospitalized. People even with self-reported COVID-19 have reported the prolonged and persistent symptoms as well. All right, this was a great study because what are the new symptoms? You recover from COVID, you feel okay, and then you start getting new symptoms and they start feeling really debilitating. What are those? So this study kind of looked at those, and a new breathlessness going upstairs I thought was really notable. So a good question to ask when you're trying to figure out what the impact is and these symptoms that are nicely described happening after your recovery. New need of a CPAP or other breathing machine when you're sleeping. And then what do we think about return to work? So the return to work, return to sport, return to school, all of these different things. It's nice to just have some baseline data that about a third of patients at the 60-day time frame have been unable to return to work. So 60 of the 200 who were had employment before their COVID. So, okay, I'm going to transition to the mild outpatients. We now have a good cohort of what to expect in the patients who hospitalized, ICU. They were severe. They had, complications during their disease. So the University of Washington did a fantastic study. It was a longitudinal prospective study that said, let's just catch everybody. Let's catch everybody with COVID. In this study, 6% are asymptomatic. They just tested positive. They had no symptoms. 85% outpatients, mild illness, no significant complications. And then we had 9% that did need hospitalization in this cohort. So what do we see? Is it the same? Is it different? Is it as severe? Is it inpatient? What are the rates? So what they did basically is they did follow-up surveys. Most of the people are reporting their survey the 6 to 9 months out from their COVID diagnosis. So 6 to 9 months out, mostly healthy people, mostly mild illness. What are we seeing in them? So this study shows the overall 31% of patients with one or more symptom persisting at the 6 to 9 month time frame. This is where when the news says 30% of patients are having long COVID, this is the study that said that's the mild outpatient population. The 30% comes from this data. And so that's very similar. The hospitalized cohort within this is 32%. So we're seeing very similar rates, hospitalized versus outpatient. The trouble breathing and the body aches are equal rates, outpatient versus inpatient in this study. And then we've got some things that are different, outpatient versus inpatient in the acute versus recovery period. But I think the most notable thing about this time is the outpatients are totally there and counting these persistent symptoms in every category in rates that are sometimes slightly different, but sometimes very similar. Another study looking at healthy people who stayed outpatient. This was a Swedish study that followed healthcare workers with mild disease. So this is a nice one because they kept testing for seroconversion. So they had a control in this study of the people who have never seroconverted to COVID. And so this is nice because they say, okay, we've got 26% of people with a moderate severe symptom lasting more than 2 months, and that's only 9% if we look at our seronegative patients. So super mild people, super healthy. In this, our seropositive, we've got 15% of them lasting more than 8 months. This study, being healthcare workers, were 80% female. Here's the data of our seropositive versus seronegative patients, and what is kind of the most notable and specific symptoms. So the change in your taste and the change in your smell are the most specific. Definitely that's our most specific when we have our seropositive versus seronegative. The most common symptom overall is the fatigue and the dyspnea. All right, so we've got the psychological and cognitive effects as well. My favorite slide ever is COVID. Please note, we've moved a few books around. Travel is now in the fantasy section, sci-fi is in current affairs, and epidemiology is in your self-help. So, what is it that's changing the psychological cognitive effects? And what we're definitely seeing it, but what is it? So we have nearly 50% of COVID-19 survivors who are saying we have a worsened quality of life. Where is it coming from? Mental health, emotional, just constant pain. What's it coming from? 22% have anxiety, depression. 23% have persistent psychological symptoms at the 3-month time frame. One of my favorite studies so far, this is coming out of Korea. This is 12 months of follow-up post your COVID. So you can see they're following lots of different psychological effects of COVID and what is happening with patients over time. And so we've got 1 month to 12 months in this series, and you can see that anxiety and depression, they're having some decent recovery over time. So over the 1 month post to 12 month post, we are recovering a decent amount there. Other things are not recovering in this case series. So the cognitive dysfunction, slight improvements, not incredible, and lots of work to be done there. And then amnesia. is not a great amount of recovery from 1 month to 12 months. Another one of my favorite studies. This study I pulled out when patients are not, their mental health is struggling post-COVID. I pull this out because they need validation. And this study is COVID-19 compared to other respiratory illnesses. The top row is COVID versus influenza, and psychological illnesses, all comers of all psychological diagnoses, and then anxiety and depression. So with those three on the top row, COVID is just leaps and bounds above influenza in all of these diagnoses. And so on the bottom row, they did, instead of COVID versus influenza, they did COVID versus URI and lower respiratory tract infection. And again, COVID is notably much higher than those diagnoses. So it was because they were isolated, it was because they went through severe anxiety trying to get a diagnosis, trying to get tested. This is in the same time period. So you think getting influenza and needing to be, tested and go through the process, getting a diagnosis for influenza during the last 2 years would have been a similar process as your COVID. So we definitely have a difference. And again, I like showing this slide to patients to be like, if you feel like this is way different than you catching a cold last year, 3 years ago, it's documented that you should feel that. Okay, how on earth is COVID affecting the nervous system? We've got lots of theories, nothing proven. Giving this talk is like grasping running water because we're still working hard on what the pathology is. But is the virus itself, it has neurotropism, we know it has neurotropism, so is it just doing direct effects on neurons? Or is it neuroinflammation caused by the virus and the neuroinflammatory pathways get activated and then we have the severe disease from that? So 80% of the patients hospitalized with critical COVID have neurologic symptoms. The encephalopathy is very well described now. And then we have all the cerebrovascular thrombotic events to weigh into the picture too. All right, does the brain structure change from COVID-19? It does. I'm sorry to say, your brain structure itself does change from your COVID-19 infections. This is a prospective study. I love this study because they were already doing serial MRIs on people 50 years plus in the UK. So they were sitting there doing MRIs anyway, watching them age. Everyone's planning to just see what your aging MRI of your brain looks like. So we have pre and post. Then they took their 400 patients who had developed COVID, who were already in the study, and they did their MRIs. This is about 5 months after their COVID diagnosis was their follow-up MRI. Those who had COVID-19 were mostly mild. So they were mild infections, not requiring hospitalization most of the time. And there's greater reduction in the functional connectivity and the structural measurements of the brain in COVID compared to people who'd not had COVID during the same study period. And it's gray matter thickness that's most impacted, and it's the orbitofrontal and parahippocampal cortices that are changing notably. The findings, so they said, let's just we have 15 and 400 who were hospitalized. Are they skewing our data? Let's pop them out of it entirely and look at the data set again, and that does not impact that we've shown the change in brain structure is there. They also were able to take several patients in the study with non-COVID pneumonia to say, let's just get people who were sick anyway. And there were not significant findings when we did that comparison with the COVID patients. Influenza was also within this population, so they did a cohort there, and there's not an overlap of findings with influenza or pneumonia or anything but COVID in these gray matter findings. So coming from that same study, again, we are impacting the gray matter in these specific areas. So what is the orbital frontal? I'm not a neurologist. If anyone want to pipe up, let me know. But orbitofrontal and parahippocampal. So the study authors give this great discussion of This is an area impacted by the olfactory bulb. So is this, again, the virus going to the olfactory bulb, doing damage there, and then being able to go to the brain and create damage there, the virus itself? Or is it inflammatory? Or is it that we've damaged taste and smell, and so the sensory data going to the brain has just completely dropped off for a long period of time, and then we're getting atrophy of gray matter because we're not getting sensation input to the brain for a period of time. So lots of information that we need from this study, and luckily we're going to keep following this cohort of 400 patients and keep comparing what we've seen before at this point. I think there's already 6 studies from this cohort, so they keep publishing as they keep pulling more data from it. Same study, does cognitive function change? So this is alphanumeric and numeric testing and doing trials of it. And what is the time to completion? And you guys can see that COVID disease, or COVID cases, much higher times to complete these specific trials done in the tests. So documented here that we're having a cognitive change. This is much lower impact the lower the age, much higher impact the higher the age. Okay, everybody's looking for biomarkers. If we find the biomarker that is what is causing the significant disease, then we have something to treat. So everyone's looking for biomarkers. They're measuring basically anything that looks like an impact on neuronal dysfunction, and then calculating neuroglial scores to estimate how much neuronal inflammation there is. This slide is busy. I'll try to simplify. So if you have COVID encephalopathy, you're in orange. If you're healthy control, you're in purple. And then hospitalized versus non-hospitalized, you're green and blue. And so your scores of neuronal dysfunction are not nearly as significant as COVID encephalopathy, but your hospitalized versus non-hospitalized are pretty much overlapping. So very interesting that we've got that significant biomarker of neuronal dysfunction in all cohorts, encephalopathic, outpatient, inpatient. So when you take those markers and then you have them do cognitive testing, our hospitalized versus non-hospitalized, they're all scoring high in cognitive testing. I guess we should say a % change in cognitive testing. So every time we find biomarkers that look like they are significant, then people are looking at what we do to impact the expression of these biomarkers, and there's everything going on. It's all experimental. We have no good data. But people are doing monoclonal antibodies, specifically looking at inflammatory IL-6 pathways and things like that to see if we have impact. Very much in the early phase. Okay, this was last summer. Last summer, everybody had figured out COVID long haul symptoms were not COVID. It was just reactivation of EBV. Okay, so what do we know now that it's been 9 months since these studies were reported? So they were small retrospective case series in the first place. So people after their COVID went back and got blood, ran the blood, the historical blood samples, they ran them for EBV titers. And in these small retrospective case series, there were 30 to 50% who did have IgM positive for EBV, showing EBV had reactivated in some way serologically. Then we've got all these caveats that have come out since then. So it's more prevalent if you were given steroids for your COVID. So then you've got this big question, well, did EBV really reactivate because COVID caused that to happen? Or did EBV kind of reactivate serologically because we gave steroids? It was more common in 50 plus, it was more common in females to see this. And then we have the other question is, are T cells, the T cells whose job it is ever, for the rest of your life after your mono, to keep mono quiescent, are those T cells just redirected because COVID becomes overwhelming? And that's the other theory. But at this point, we're not saying that we have larger studies than this. And I've been doing my own mini studies, so my own long haul patients of persistent post-COVID, I'm grabbing EBV samples just to look and see if I'm seeing it. And I have a huge portion of them who are still EBV naive. Not only are they not reactivating, but they're still EBV naive. So I don't think this is the link that's going to figure everything out for us. How long will symptoms last? So it's nice to have just some guidelines to tell patients. The fatigue is by far the most common symptom. It's profound, may last for months. You can say 3 months are going to be really bad, but again, we've got these caveats of if you were an ICU survivor, if you had lots of complications, then it's going to be longer. The dyspnea, the chronic cough. So again, we've got recovery nicely described under 3 months, but we also have nice studies that say this can be persistent at 12 months. The altered taste and smell, the majority have, at 30 days, the majority are recovered from this. But we have lots of patients who are getting the symptoms persisting longer. I have lots of patients who the symptoms went away, recovered nicely. They got vaccinated and they lost taste and smell or had some alterations for 2 weeks or so after vaccination, recovered, boosted, you lose it again. So it's so interesting, and the pathology needs to be continued to be worked on. Can we prevent long COVID? So good data showing we vaccinate, and the vaccination helps us prevent COVID disease, and then we're able to prevent long COVID. Masking, social distancing, hand hygiene, all on this list as well. The data comes from pre-Omicron. So that means the more transmissible variants that had immune escape to the vaccine are not in the cohort of studies prevention of long-term symptoms. But before 2022, here's the data. So did first dose of vaccine and second dose of vaccine impact the persistence of symptoms? And yes, it did. So after you got your second dose, if you're under 60, it's a really big change in symptoms lasting more than 28 days. So I think that's good data. I'm waiting for the next wave of data to come out on the same topic, but under 60, it's a big change. Over 60, it's still a notable change that the persistence of symptoms goes way down. The chance of persistent symptoms goes way down after the second dose of vaccine. Management. Okay, you've got lots of different guidelines. You've got NIH, you've got Stanford Hall, you've got CDC, all giving you guidelines that you can read through on management. So you've definitely got these to go through. My favorite one, patient handouts that come from the UK. I can send links to anybody who wants that link, because they basically just went, you're having a lot of dyspnea. Well, what should you do? What should you expect? And they go through a patient handout type of way. Same thing with your fatigue, your muscle weakness. Let's go through. So I love the patient handouts that the UK has done for this reason. The US is trying to catch up. So you guys, our White House gave an official memorandum saying we have to address the long-term effects of COVID-19. They gave this during April of 2022 and said we've got to put money and studies to really knowing what the effects are and how to manage them. So how should you deal with the patient when you're seeing them in the office? My overall biggest recommendation is that you're super comprehensive. Make sure these patients have a lot of time, because you're going to be super comprehensive in your history and physical. You've got to spend some time going over pre and post-COVID functioning, and then you've got to review the COVID disease and what all the symptoms were during their COVID disease. So you're going to ask all about, well, what was your course? Did you have clots? What was your kidney functioning during it? What cardiac complications were there? How did you feel neurologically during your COVID? You're going to go through all of that. And then you're going to review subjective reports of their cognition and their mental health, and then go through past medical history significantly and figure out what in the past medical history is impacting them from this overall global health perspective. Which lab should you do? So for sure you're doing a CBC and a CMP with persistent complaints once you're kind of over that 4-week time period. Plus minus, the CRP and the ESR, if they're having persistent fever, chills, bone pain, you want to look at that. Looking at cardiac markers in patients who had any complication from heart failure or myocarditis, anything like that. If anybody has any complaints or any concern for thromboembolic disease, you're getting a D-dimer. Thyroid studies in anybody with persistent fatigue. I usually throw a vitamin D in there. It's low most of the time. Getting a creatine kinase in patients with muscle weakness or muscle tenderness that's persistent. If patients don't know that they had COVID or not, they think they had COVID, but they don't know, they never got tested, go ahead and order the viral antibodies as well so that it's confirmed or not confirmed. This becomes an issue if it's 6 to 9 months post the COVID, because then the antibody can be waning for other reasons. All right, you guys, I'm gonna go fast a little bit. So, persistent pulmonary cardiac symptoms. The workup, first of all, you're doing orthostatics, laying, sitting, standing, 5 to 10 minutes between each. Orthostatics, trying to get information on where is it coming from, and are palpitations coming from significant changes, becoming very tachycardic, orthostasis, and then going through that. The lung exam, we need to figure out if there's any signs of pulmonary fibrosis or an effusion or consolidation. And then doing an EKG, so looking for the arrhythmia right there. If the fatigue and the palpitations are significant, being able to arrange for a Holter monitor is helpful. If there's the history of myocarditis, getting a follow-up echo. And then return to sports and activity is monitored really closely. But if there are persistent pulmonary cardiac symptoms, everyone's basically getting a no on return to sports and activity unless everything is resolved for a 4-week period of time. So that's where we're at now. It's going to change, but I'm just telling you where we're at now. So a lot of the reasons we're being very careful with people with return to sports and activity is because of the VA study that's going out 12 months for cardiac risk. And we basically have 23 excess cardiovascular events per 1,000 in the cohort of people who had COVID-19. So we're definitely seeing 1 year out more cardiac events overall. So atrial fibrillation is really common. And then we have heart failure, cardiomyopathy, the thrombotic events all noted, acute coronary disease and myocardial infarction all are notable here. So they're just on your level of watching closely, being kind of a heightened sense of what needs to be done. Persistent pulmonary symptoms, I'm going to summarize really quickly since I'm running out of time. But you're basically going to perform chest x-rays if they're having persistent symptoms at the 12 weeks. If you know you've got to follow up on something, so you know they had terrible chest CTs, you know they had terrible chest x-rays before, making sure you get a follow-up chest x-ray, and then if things aren't resolved, sending to pulmonary or sending for a chest CT for follow-up. So that's kind of at that 12-week time frame of just saying, let's just check the chest x-ray and know where we're going to go. So that's being impacted by this study. So this study took our hospitalized patients coming out of Wuhan, China, and showed that even those people who were kind of resolving on chest x-ray, so when we do their diffusion capacity at 6 months, 56% are still abnormal. Managing persistent dyspnea. So with this one, the big thing to notice is to really be comprehensive because it's often multifactorial why they're still having dyspneic symptoms. But if we have an organized pneumonia and we knew they were an ARDS patient, the studies now show that we get a lot of help by doing a 2-week steroid course. So you've got this population here to note that say, okay, I know they had a rough hospitalization course. I feel like something is brewing. That's your moment to do a 2-week steroid course. The dysautonomia patients are fascinating. You guys know POTS and dysautonomia patients. Manage them behaviorally with compression stockings, hydration, salt intake, physical therapy, and behavioral modifications. So that's your big overall. All of the POTS medications right now, people are trying to stay away from and see if we can just manage the orthostasis and dysautonomia symptoms without it. persistent neurologic symptoms. So let's go through the continued muscle weakness or sensory complaints, making sure that they get referred for a nerve conduction study and the EMG. And then if the brain fog is persisting and notable, then you're going to want to do a further evaluation. All of the tests I listed here are ones that can be done in under 10 minutes in the office. So there's definitely an option of getting a good feel of how impacted cognitive symptoms are. Don't have time to go over the slide, sorry. But basically with persistent fatigue, you're just going to keep going through what symptoms they are, pre and post functioning, and then working on a very slow basis on recovery. The smell and taste, this is where the patients who are really frustrated that this is lost at 6 to 12 months, they are starting to do olfactory training kits, and there's not good data on the response to this, but if you read the Amazon reviews, everyone is sure this is the way. So doing the olfactory training kits and doing the self-guided online programs is the way. This is my last slide I wanted to follow up. This study came out a week ago, and it was fascinating, and everybody says Paxlovid is how we're going to cure long COVID. So caution, 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 caution. This is a case series. That was the news, right? It was there in the news. Everybody was giving their reports. Cure long COVID. This is a case series of 3 patients out of UCSF. 3. So hold on to your Paxlovid. And it's super interesting because basically one of the patients, Paxlovid given early in acute phase, created rebound symptoms and then long COVID persisting after that. So given an early phase. Then 2 patients given in a late phase had resolution of long COVID symptoms. And there are your 3 patients. 3 patients. So that's basically UCSF said, if we have NIH funding to do a very large study, we'll give better answers. Okay, all caution given. The other caution given when you're feeling like you've got long COVID symptoms and you want to feel better is make sure you know there are 608 drug-drug interactions with Paxlovid. So make sure you're running your drug-drug interactions. There's lots of databases now that will do Paxlovid drug-drug interactions for you. All right, that is all. Any questions? My email is here. This is one of my other favorite slides. The doctors who are tired of COVID and the doctors who are tired of COVID, but in yellow. We are going to keep working on this, though.
Oh, there we go. All right, so we do have a couple of minutes for some questions, and we're gonna, if you have a question, raise your hand. I'll come out to you, or line up at the 2 microphones that are here. But we're gonna start off. I have an online question for you from Dr. Bailey, and Dr. Bailey wrote that there's been some patients with significant tonal and auditory distortions. And decreases in hearing frequency, but he says he sees this less commonly than taste and smell impairment. But even though it's less commonly reported, should auditory changes be considered just temporally associated or causal?
I'm not sure. So it's not well described as one of the more common presentations, but we're still gathering data on how it's presenting. So, and again, be comprehensive. That's my overarching. If you think you need to evaluate people's hearing and see what the differences are, go ahead and do it. Still lots of information to learn about COVID.
Well, perfect. Oh, we got a question over here.
It's sort of a follow-up on the olfactory test or training. Do you think there's any place for physical therapy for people who are maybe a combination of wasting and other things besides the neurologic issues in terms of helping people get back on their feet?
Yes, sorry, that was one of the slides I definitely skipped when I had to go fast over the busy slide. But physical therapy, especially when you have them focus on just endurance and just core strength, that seems to be where physical therapy should focus with people having significant weakness and fatigue post-COVID. And finding a physical therapist who's done it before.
Great. Any other questions for Dr. Smith? All right. Thank you very much, Dr. Smith. Appreciate it.